where health meets faith, a podcast that explores connections between spiritual and physical health. Intersection is a production of Mount Sinai Ministries, Cleveland, Ohio. I'm your host, Mark Ribbons. I'm program manager for Stopping Cancer in Its Tracks, also known as SCIT, the faith-based community outreach focus of Cleveland Clinic's Taussig Cancer Institute. SCIT interacts with faith communities around Northeast Ohio to connect congregants and the surrounding communities with cancer education, screenings, access, and navigation. Today on the pod, we're talking about the representation of Black Americans in medical research and cancer clinical trials. We are honored to have Dr. Adjei, chair of Cleveland Clinic Taussig Cancer Institute, as our guest. Dr. Adjei provides dynamic and insightful leadership at Taussig, as well as coordinating cancer care and research at Cleveland Clinic main campus and regional hospitals. He's also the editor-in-chief of the Journal of Thoracic Oncology. There's a mouthful. Doctor, welcome in. Good to have you here.
Thank you, man.
Tell us a little bit about Alex Adjei. Who are you? Where'd you come from?
So, brief history. I was born in Ghana, in West Africa, where I went to medical school. And after I finished medical school, when I was in my final year of medical school, there was this physician who had come from UK who was studying the local herbs, but he had no scientific training. So what he will do is, back then, you go to the herbalists, we call them, and they'll give you a bunch of leaves and ask you to boil it and drink it 3 times a day, something like that. And he wanted to really find out whether this worked. So what he went about doing is he would take a bunch of leaves and weigh them so that he would tell you, we have half a pound of this, add 20 ounces of water, boil it, and drink 2 ounces 3 times a day. So he tried to calibrate the dose and so on. And actually, some of the herbs really work. There was one for high blood pressure, that worked very well. One for diabetes, that could lower the sugar. So I got interested in it and said, I'm going to go and do some research and try to figure out how to get the active ingredient from these herbs so that it would be easy for folks to take. And so I went off to Canada after medical school in Ghana. And it turned out that where I went to study pharmacology, the only person who was doing something that was related to the clinic was doing it in cancer. So I did research in cancer and how to treat cancer in the laboratory. So then when I finished, I wanted to become an oncologist. So I came to Howard University and did my residency. Then I went to Johns Hopkins to do my fellowship. And I was recruited to Mayo Clinic, where I started my career. Spent 11 years there, and then was recruited to Roswell Park in Buffalo to head the Department of Medicine and oversee their clinical trials. So I was there for 9 years, and then they recruited me back to Mayo Clinic because they wanted to build the program in novel treatments for cancer across their 3 sites. They have a site in Minnesota, Arizona, and Florida. So I was brought there to pull all of it together and actually managed to do it in about 3 years, and I was there 6 years, and then somebody called me, hey, would you like to come and look at Cleveland Clinic? Yeah, so I came and visited, loved the place, and here I am.
We're happy to have you here. You've been here at the clinic for about a year now, and have had a chance to survey some of the community and some of Cleveland Clinic's reactions and interactions within the community. What are some things that you, coming from the outside, see as far as Taussig reaching out?
Well, so I'll have to say that compared to some of the big institutions in, let's say, where I trained in Baltimore, where you have the big institution in this African-American neighborhood. And I remember when I was there, folks who are a block from the hospital
if they had any problem, they went to Liberty Medical Center, which is like 10 miles away, right? Because they didn't feel welcome at Johns Hopkins. And that pattern exists across the country, right? And a number of times it's not that the institution or the folks there are setting out not to welcome people, but it's just the interaction and so on. So when I got here, I was impressed to see that there's a lot of outreach in the community, right? So I have to say that compared to some other cancer centers, I was happy to see that Taussig is doing a lot, right? But what struck me was after I got to know the team and what we're doing and so on, the one thing that struck me was that we are doing a lot in outreach. We are doing a lot of screening and being able to catch some of these cancers early. But still, when I look at the patients who come through Taussig, we don't see a lot of people from our community coming there to get care. So one of the things we are focusing on, of course, is number one, we have to screen, because with cancer, if you catch it early, you can be cured. But unfortunately, you don't catch everybody early. And so sometimes you catch it late, and we want to give the best treatment possible. So we have to make sure that everybody comes for screening, but unfortunately, if you have the cancer and it's late, come to us, we'll take care of you.
A great portion of the work of the faith-based outreach, Stopping Cancer in Its Tracks, is making sure that congregations like here at Mount Sinai Friendship and around the city are not only connected inwardly with the membership, but also with the surrounding community to make sure that the barber and beauty salon or the laundromat down the street knows that by connecting with Mount Sinai, their patrons can know you have a connect with Cleveland Clinic if you need a mammogram, if you haven't had your prostate check in a couple of years. How important do you see the community connection between surrounding community and congregation and Taussig?
I think it's really, really important. I think the way I look at this is that if you are fortunate enough to be living next door to one of the best hospitals in the world, you need to take advantage of that location, right? And so I think it's really important what Skate is doing, getting people connected to be screened, and if we find cancer, come to Cleveland Clinic to get care. I think it's very important.
Yes. So in 2022, part of the Taussig team, Heather Hurwitz, I'll shout her out because she's in the audience, put together a listening tour. We wanted to not only go out into the church and the faith community and tell them about early detection and tell them and educate them about the different types of cancers, but to hear what the congregants had to say to us, and particularly on the subject of research, because that sometimes is the elephant in the room that's unspoken, particularly when we speak to the Black American community, of how important it is to be involved in research and why sometimes there's reticence of our community to be involved. Let's touch on that for a minute. Why do you think that, first of all, the amount of disparities in clinical research are there, and why does it matter that the community becomes more involved in research?
The disparities in research is complex. I think it first started off by, if you're going to take part in a research program, there's going to be a sheet that you have to review that tells you about the trial, what it's supposed to do and what the trial does and so on, that you have to agree to take part in the trial. This is called the consent form. And I think that things are getting better, but initially when things started, the consent form was such that it was difficult to understand. And then about 15, 20 years ago, there was this push to make the consent form simple enough so that somebody with an 8th grade education can read it. Well, what about the person who had only a 4th grade education? Yeah. Or the person who maybe didn't have any education at all? How are they going to maneuver this? So it's a challenge. It's a lot of information. And if you are just going to get your regular treatment, your doctor tells you the treatment they are going to use, maybe the side effects, and you go. But here you are given a 20-page document that try to explain every possible thing that could happen and so on. So that has been a barrier to the African American and a lot of the underserved communities. They're just trying to understand the complexity of this trial. And then, secondly, sometimes the trials were written such that to take part on it, you have to be a superwoman or superman, in the sense that your kidney function has to be perfect, everything has to be perfect, right? And we know that in African American community, there are a lot of folks with hypertension, high blood pressure, diabetes, and so on. And I'll digress here. One thing that we didn't even know before is that, your white blood cell count that we use to make sure somebody can go on the study. In general, we don't understand the basis of that. But African American folks, our normal white count is a little bit lower than the general population, but it's normal. We know that now, but we didn't know it then. So a number of the criteria that are needed to get you on the study are such that you might be disqualified from going on the study. The other thing is that the studies have been complex in the sense that maybe if you are going for regular treatment, you go once every month. And on the clinical trial, you might have to go once a week. And if somebody has to take time from work, has to look for babysitters and so on and so forth, they just can't do it. It's too complicated, and that's part of it. And then the other part has been our physicians sometimes, when they are explaining the study, forget that we are talking about fathers and mothers and so on, right? So you have to think about the patient first and what's important to them and what benefits them. But sometimes we are so focused on the trial that to the patient, we sound like a used car salesman. It's like you are trying to convince them to go on the study. But that's not the point. The point is that the point should be that you want them to go on the study because it's the best treatment for them. And a number of times we don't send that message, right? And then, of course, there's the history of discrimination in this country and, the Tuskegee experience and so on. So there's distrust of the medical system, right? So folks feel like you want to use them as a guinea pig, so we have to work hard to overcome that.
This is Intersection. We're talking with Dr. Alex Adjei, who is the chair of Taussig Cancer Institute at Cleveland Clinic. You raised a wonderful point that's not always thought of when we're doing our outreach type of work, or even to the people that we reach out to. When we talk about barriers, when we talk about disparities, literacy can be a major problem. When trying to we have these wonderful doctor-researcher minds who have a necessity to break it down to the simplest terms possible, and that's not always easy.
Exactly. So it's a real problem, and something we are working on because we haven't fixed it yet. We've sort of come to accept the disparities that might be due to language barriers, right? So depending on which part of the country you are, you're going to, the clinical trial itself is there, but that consent form, you're going to translate it into Spanish and so on and so forth. But just taking the English that we write and trying to think about how we can simplify it even further so that the person with little education can understand it. The other thing is how we treat our patients, right? Because, and it happens a lot, if I'm an African-American patient and I meet this white doctor who I think or I sense actually comes in with a condescending attitude and so on. Even if I don't understand something, I don't want to ask because I don't want to look stupid, right? So the simplest way out is I won't participate in the study at all. So it's a lot of work that needs to be done.
Wow. That is one of the comments that we ran across on the listening tour was the reverse, I guess, of no literacy is patients who felt, my doctor talks down to me. My doctor speaks to me as if I don't understand anything.
Exactly.
That's a difficult balancing act. So why should cancer research matter in medically underserved communities? Why do we preach this gospel?
Well, so there are a couple of things. With cancer, let's take lung cancer, which I treat. When I started out at Mayo Clinic, I still remember this. My first 25 patients, every single one of them lived for only 4 months.
Wow.
Yeah, because the treatment we had then didn't work. And now, so this was late 1990s. Now we are in 2023. And I remember I said the first 25 patients, they lived 4 months. Now I have over 10 patients who are alive, with stage 4 non-small cell lung cancer that has spread. They are alive after 10 years. I have like 20-something patients who are alive after 5 years. And I actually have one patient who I first treated in July 2000. Oh, wow. So this is 2023, right? One feature about all these patients is that almost all of them were on a clinical trial, right? And with cancer, because we haven't done well in treatment, we are all testing new medications, right? And so the clinical trial, a lot of times, is your opportunity to get the medication of the future. The drug that's going to be approved in 2026, 2027, we are testing it now. And we are testing it now because we have reason to think that it's better than the treatments we are getting now, right? So getting on to a clinical trial a lot of times is the best that you can get. The other thing that makes it important also is that, in the clinical trial, everything is written out, everything is done according to what we call a protocol. So it means that even if your doctor isn't there and somebody comes to see you, they can't change the treatment. They are going to do the same treatment that you get. The other part is that sometimes on the clinical trial, there's this new treatment. We don't know how good it is, so we're going to add it to the treatment we have now. And sometimes in the middle of that trial, we find that those on the new treatment are doing better than those on the current treatment we have. So what do? We stop and put everybody on the trial on the new treatment. Okay, so with cancer, when we do it right, we tell you about the clinical trial because it's the best that we have. And so if people are not getting onto these trials, then they are not taking advantage of the best treatment out there. And that's part of the reason why a lot of times, regardless of any cancer that you see, the underserved populations do worse. With the same disease, same stage, they do worse. And part of it is because they don't get these clinical trials. they don't get on them. The other thing that's really important for particularly the African Americans and other ethnic minorities is that think about this. You have a new drug. If it's approved, you're going to use it in America. And this is a country where a big chunk of the population is African American, Hispanic, and so on. So if you test this drug on 98% of your people are white men and women, the drug gets approved. At that time, we don't know what the drug does in black people, right? And we know that there are some medications where the side effects can be different depending on the group you're in. And some of it is just that, that's why we talk about ethnicity, because it's not just a question of race. It's your culture, your habits, the diet, So there are things we do as African Americans that might be different from another group, and it's not our skin, right?
Sure.
But it's the diet and our lifestyle and so on. So a lot of things are different. So common sense will say you have a new drug, you are trying to test it and give it to the population. You have to make sure that you're testing it in your whole population so that when the drug is approved, you are comfortable that it's safe for everybody.
Certainly. Let's talk about the importance of protocols, which you mentioned, because again, within the focus groups, to a date, every time that we went out, someone mentioned Tuskegee experiment. And, we're very focused on listening, but our nurse practitioner who works on the team, Pam Combs, talked about the fact that there are safeguards that have been put in place so that these types of things are guarded against. Talk a little bit about protocols.
Yeah, exactly. So, the history of medicine has come a long way, So even back before Tuskegee, what led to some rules about how you can do research was after the Second World War, when they found that the Nazis were experimenting on Jewish patients without their knowledge, without their consent, and so on. So some rules were put into place, but clearly they were not good enough because, the Tuskegee experiment happened after that. Right, and now there are a number of regulatory bodies, including FDA. Every institution has an institutional review board, which is made up not only of doctors and scientists in the institution, but they are lay members of the board. And their job is to look at every research and make sure that the safety of participants is protected, right? So right now, it's impossible to do a study without explaining to the patient what they are going to do, right? So sometimes, apart from Tuskegee, one of the things that people worry about the most is, if I go on this study, how do I know I'm getting the real drug, right? Maybe it's a sugar pill. Right? So maybe they are not giving me the drug. And the point is that, yes, they've done that in the past, but now you can't do that anymore. If one group is getting what we call a placebo, which is a sugar pill, it's spelled out. It's not that we are going to tell you you're going to get a placebo. We are going to tell you, if you go on this study, there's a 50-50 chance, right? So these days, it's really very difficult for the system to do the kind of thing that we saw with the Tuskegee experiments, because there are a lot of safeguards.
Let's flip over to what is happening at Taussig. In the year that you've been here, I've heard you in a speech before talk about your passion for research, and talk about the fact that you would envision seeing novel treatments in research, novel research projects going on at Taussig. What do you envision moving forward in maybe 5-10 years?
Well, yeah, so like I said, right now we've come a long way, but we don't cure cancer. And even if we define cure as we are going to control your disease so that you die from something else, we are not doing that. So even with our best treatments, most people with cancer will die from the cancer. So it means that we need to improve the treatments. And there are different types of trials you can do, but the way to improve the treatments and have people survive long, and from my standpoint, the goal is that if we don't, so there are a couple of things. So the research we're trying to do in multiple places. The first is what you're doing with SCIT, which is let's screen and catch the cancer early. Because when you do that, you can cure the disease, right? And that's part of research, because normally what you do is you sit down and somebody will come to the hospital to be screened, right? So that's regular treatment. But if you go out in the community to educate the community and bring them in to screen them and so on, that's part of research. So screening and early detection is the first thing. Then unfortunately, if that doesn't work and you catch the cancer early, the idea is to look at new ways of treating the cancer. So what we are looking at now, what we mean by the novel therapies, is where we are testing new methods for treating cancer. So I'll give you an example. Something that seemed impossible in the past that we are doing now is that now we can take a virus. Let's take the virus that causes colds, okay, and modify it so that it doesn't infect your normal cells. Mm-hmm. It only gets into the cancer cells. And give it to the patient who has the cancer. It's not going to get into all the cancer cells. It gets into a few of the cells. But it's a virus, so it doesn't belong in your body. So your immune system is going to say, okay, this virus shouldn't be here. We should kill it, but the virus is in the tumor. So the immune system is going to recognize that cancer cell. And so, as it were, you're using the virus to tell your immune system to see every cell that is cancer as not belonging, so that it goes out and kills all of them, all right? So it's a way of indirectly priming your immune system to recognize cancer cells as not belonging in your body and take care of them. And these are things we are doing. That's part of the research. There are other areas of research with, let's say, radiation, where in the old days, if you have a spot in your lung, the machine is trying to treat the tumor, but it affects your normal lung. So the tumor might be gone, but you now have lung inflammation and so on and so forth. And now we have ways of pinpointing the radiation just to the tumor to take it out, right? And that's all through research. So there are a lot of new approaches we are testing. That, number one, is more effective, and number two, has less side effects, and basically will help prolong people's lives.
That's exciting. Now I can see why you're so passionate about cancer research, because just the idea that you were explaining about the cold virus, how that could work, that had so many awesome possibilities exist
Exactly.
there.
Yeah.
Talking with Dr. Alex Adjei, the chair of Taussig Cancer Institute at Cleveland Clinic, and we're talking about research, and particularly as it connects to the African American community in Cleveland. As our faith-based communities and the groups who are a part of SCIT reach out to people for screenings, for education, one of the things that we get back as feedback a lot is, I don't want to know. How can our advocates speak to, for example, gentlemen who, I haven't had my prostate numbers done in a couple of years, I don't want to know, or I don't want anything to touch me down here. What are some strategies that we can look at moving forward?
I think the best strategy, and you harped on it, which is advocates, right? I think the most powerful thing, more than what you can say, I can say, Heather can say, and so on, is to have somebody there who says, I had my PSA checked, and it was high, and I went in and did my surgery, and now it's been 10 years.
Okay.
Right? And so I think when people see somebody who's been through it, where the cancer was caught early and did well, then they're going to now want to do it. So I'll tell you a quick story. Like I said, I was born in Ghana. I try and go every year. And the thing is that, if you didn't know anything at all, the reason you know all of us black folks come from Africa is that you go to Ghana and the cancer problems we have are exactly the same as what we have in our African American community. Prostate cancer, very common. Breast cancer, very common. The same issues. And we face the same issues of particularly the men, not wanting to go for their checkup and so on, and you hit on it. A lot of them are afraid, right? And so we had a symposium where I gave a talk on prostate cancer and the fact that it's treatable and so on. And I think the best thing that we did was in the panel, we had someone who had had prostate cancer and had had surgery. So he basically addressed all the issues that men are concerned about, right? Because one of the things that is not talked about a lot is that a lot of men, they have the prostate cancer and they have the surgery, and it's been known that sometimes, after prostate surgery, you might be impotent, right? So sexual function, it becomes very important. What people don't know is that the research I spoke about, right? Back in the day, when the surgeon went in, you have cancer, they take out everything, right? And they found out that back then, almost every man after the surgery is impotent. Then they figured out, well, with modern technology, we can actually identify the nerves that are important for men getting an erection. And we can move those nerves out of the way and take out the prostate.
Wow.
Okay? And so technically they call it nerve sparing surgery. They are sparing the nerves. They don't cut into them. So that right now, that problem that a lot of men are concerned about is very rare.
Wow.
But they don't know that, all right? So they need an advocate to say, well, I went through the surgery, and this guy was funny. He said, I went through the surgery, and you can talk to my wife. And I'm pleased to say that, I got a lot of calls, a lot of people were now going to screen and so on. So I think we should really use our advocates, because there's nothing like seeing somebody who went through it and came out well, because it's so treatable. And so it's sad to get somebody diagnosed at a late stage and die from it when it's all preventable, right? There are certain things we can't prevent because we can't even screen for. And even the cancer, there are some cancers that are difficult to screen for. Sure. But when it comes to colon, prostate, breast, and so on, we should be doing a much better job.
Well, we know that you are a man who has an institute to run. We're not going to keep you too much longer. But we do have some questions that came in from our focus groups, if I can just ask you those. One of our focus group participants says, is there ever a time when it's too early or too late for a doctor to suggest I take part in a clinical trial?
Too early, probably not. Too late, yes. Because a lot of times with the clinical trial, because you are testing new treatments, you want the person to be fit. right? Because if the person has a lot of problems and so on, they may not be able to complete the trial. If you are testing a new drug where you are not sure of all the side effects, you want somebody to be pretty healthy because you don't want to cause harm. So if you don't take part in the clinical trial and wait too long, then it might be too late. And I've seen folks like that who initially will say they don't even want any treatment, right? But when they are now having pain and so on and other symptoms, then they want the treatment. And sometimes by that time it's too late because if the cancer has now gone into your liver so that your liver is not working well, since most of our medications get broken down in the liver, you can't go on the study because you don't qualify. Right. So it can be too late to go on a clinical trial, never too early.
Okay. Another of our group members asks, what's being done or what's being considered to encourage African Americans to participate in clinical trials?
What we are doing now is part of it. And I have to say that through a lot of advocacy and so on, the FDA, which is the government body that oversees all drug trials and so on, now they have a document they are advising all people, all companies doing clinical trials that their clinical trial participants have to be diverse, right? Because everybody now accepts what I said before, which is that common sense tells you if you are going to use a drug in a population, at the time you are testing it, you have to make sure that the population is represented. It doesn't make sense to test a drug in one group and then go out and use it in everybody when you don't know how it works in the other groups, right? And for the first time, the FDA has come up with a guidance telling all pharmaceutical companies you need to make sure that you test your new medications when it's been tested before it gets approved in a diverse population. So that's going to help.
Great. And finally, another participant asks, when research is done, how readily available are results of research to the community at large to work against the fears and doubts that may be out there?
So that's actually a very good question, because I can tell you that up till about 10, 15 years ago, when the research is done, sometimes the results were not even published, right? And the government came up with an initiative which, number one, now before you do any human research, a clinical trial in this country, you have to register it, right? So there's a site called clinicaltrials.gov, a website. When you go there, every clinical trial that's open, that's recruiting patients, is there. You have to register it. And the other thing they did was to say, when you finish the clinical trial within a year, you have to post the results, right? So these days, the results are readily available in short order. But what happens, as you can imagine, if the results are good, you hear about them very quickly. If it didn't work, it might take a while for you to hear about it. But the thing is that if we do a clinical trial now and we finished this year, the results came out in December of this year, and this is a new treatment that's really good and so on, it might take another 6 months before the FDA approves it. And then once the FDA approves that drug, it might take the company another 3-4 months to ramp up to get it out
for production.
Right? So it might take 1.5 to even 2 years for the general population to get the drug. But guess what? If you took part in the clinical trial, you have a leg up. That's why the clinical trials are so important. The other thing that's important is that there's one part of also the clinical trial. It's kind of like a clinical trial. It's called sometimes we call it the expanded access program. Mm-hmm. So what the company then does is, new drug, it works well for this cancer, is not approved yet. It might be another 6 to 8 months before it gets approved, and another 8 months before it gets to the market. But they have an expanded access program, which is also like a clinical trial. You have to be registered and so on, and then you can get the drug early. Okay, so it's really like a clinical trial because you can't get to your neighborhood oncologist and get that drug. You only have to go to sites like Cleveland Clinic and so on that participated in the trial, and they'll have this expanded access program. And so you can get the drug early.
Dr. Alex Adjei, who is the chair of Taussig Cancer Institute at Cleveland Clinic, thank you for taking time to share insights and information with us today. And thank you for the work that you do.
You're welcome.
You have been listening to Intersection, Where Health Meets Faith, a podcast exploring connections between spiritual and physical health. For more information on SCIT and stopping cancer in its tracks, or if you need to sign up for cancer screening, visit ccf.org/cancer community outreach. That's ccf.org/cancer community outreach. Intersection is a production of Mount Sinai Ministries. Visit them online at mountsinaiministries.org. Thank you.